Non. Après, vous pouvez avec la souris montrer.
Mais de toute façon, on peut toujours utiliser le pointeur, mais sans pouvoir défiler. Quoi. Donc
c'est compliqué, autant le faire ici.
Bah ouais, je pense. Bon, après, chacun fait comme il veut. Hein. Vous êtes libre. Do you have to see the technician? No, that's fine for you.
Mais moi, je comprends pas que ça soit
Going to call his colleague.
No, I remember you. I remember your yeah, I met you, but I didn't remember the name. Okay, good. So I'm excused.
But you were already at the museum.
Yeah, okay. Well, I've been at the MSC So everything is ready?
se mettre. Hein. Tiens, si jamais tu as besoin. Tu les connais, mais... Nena Ogboulafort. Docteur Nena Ogboulafort. J'ai du mal avec Ogboulafort. C'est bien ça, Ogboulafort. Un F, hein? Bena, the name of Nena is Ogboulafort. Fort. Putain, mais quel nom? We need to take a picture of the presentation to put after in the... Tell Susanna? Perhaps you need to take some picture, then we can put that in the report after that. Okay. 3 minutes. If there is technical problem?
No, the thing is, I want you to be able to respond to questions online so that there's not every question that... It's not a big deal if you can
Tu fais une petite introduction.
Ouais. Je fais une petite introduction, je dis bonjour, merci d'être là. Avec mon collègue professeur Jean-Louis Ndiaye, nous avons de l'Université de Thiès. Nous avons le plaisir de gérer cette session sur OPT-SMC. On va faire une présentation générale, 4 présentations de projet, une synthèse, et puis après on aura 30 minutes de discussion. C'est bon?
Oui, 15.
15?
Tu fais les 4, 15 minutes, ça fait 19. Fabien, moi, 15 minutes, ça fait 15.
D'accord. Autour de 20 minutes. Tu veux de l'eau? C'est bien que ta femme soit venue.
Ouais, elle voulait absolument venir.
Bah, bien sûr. Normal.
J'ai un ami qui était venu.
Ouais. D'accord. C'est l'avantage. Ça va aller. De toute façon, t'es sur le bon chemin. Jean-Louis, c'est ça qu'il faut penser, quoi. Maintenant, c'est bon, quoi. C'est lancé, quoi. Puis Emmanuel, elle est sympa, quand même. Très gentil. Elle est vachement humaine, quoi. Après, l'autre, je ne connais pas. OK. So, hi everyone, good afternoon. We will start on time. It's 2 o'clock. So thank you very much to be here with us. So this session is about seasonal malaria chemoprevention. I have the pleasure of chairing this session with my colleague and friend, Professor Jean-Louis Ndiaye from the University of Thiès. Myself, I'm from the Special Program of Research and Training for Tropical Disease Research at Geneva, in TINEA. The name is TDR. So we will start with a short summary of the OPT-SMC project that will be presented by Professor Ndiaye. And then after we will have 4 presentations that are 4 projects conducted by a National Malaria Program that were part of this huge project. And then there will be like a summary of all this and the lessons learned. And we will have around 20 minutes for question and discussion around this project and about seasonal malaria chemoprevention. So let's start. Professor Ndiaye.
Thanks, Corinne. Good afternoon, ladies and gentlemen. I'm very pleased to present today our regional partnership we put in place between 4 institutions, 2 academic, the London School of Hygiene and Tropical Medicine, University of Thiès, where I'm from, Medicine for Malaria Venture, but also WHO TDR, with 13 countries, with 13 national malaria control programs that are implementing SMC in order to really strengthen their capacity of developing implemented research projects in order to increase the access to SMC, but also to increase its impact. So since 2018, the WHO analysis showed that malaria indicators really have not improved, and then the emphasis of full use of proven tools, and SMC is one of them. And in this map, you see that even if child survival has improved, but malaria mortality remain above 10% for many countries, that high burden, high impact countries. And in the map behind the Malaria Atlas maps show that the malaria prevalence and malaria mortality remain very high. And malaria is a leading cause of death in many countries, but particularly in this high burden, high impact country, where 6 of them are in the Sahel, so are implementing SMC. So that call, OPT-SMC, is optimizing seasonal malaria chemoprevention, is to really reply to that call of WHO, to really put the emphasis of SMC in that eligible countries. So SMC stands for, it's a community-based intervention. It's a monthly administration of 2 very effective antimalarials, sulfadoxine pyrimethamine currently, and amodiaquine, for given door-to-door in 13 countries for monthly administration, 3, 4, 5 months during the rainy season, and where malaria is highly seasonal in that country, where the high burden is also in young children. So 6 of these 11 countries, high burden, high impact country, includes SMC eligible countries. And since 2012, I think it has been successfully scaled up in many countries. In 2019, we can see that a total of 85 million treatments have been administered, 22 million children covered, but still a gap of 8 million in 2019. We observe that most countries don't have good data to really have coverage estimate of this intervention, but also not all children receive the drugs. High coverage has been obtained in many countries, in many areas, but not everywhere. So that's the reason we show this map showing that it's still a public health success story, the SMC, since the operational research, since the adoption, the implementation, and the delivery of this campaign. We reached from 2 million in 2012 up to now 50 million in 2022. You see that all eligible areas have been virtually covered, but of course, we can see by the time there's some discrepancy, some gaps. You see in some countries now, they have 3, 4, 5 cycles because we are just highlighting that in some areas, the malaria epidemiology, the malaria is going outside the 4 months interval previously recommended by WHO. And you see that also is going now outside the Sahel. We have 3 countries in Tanzania, Uganda, and Mozambique who's also starting to implement SMC. Seeing that very success story, you see that coverage also, the monitoring show that the countries really implement this strategy very successfully, despite those gaps, despite the fact that all children are not fully covered, are not taking all the cycle, despite that the fact that the high-risk children also sometimes, or the hard-to-reach population are not reached by this intervention. So the aim of OPT-SMC is really to work with the country to identify their gap, to identify the barrier, and to see how they can overcome these barriers, but also to see how they can monitor its effectiveness. So as objective of this program, we work with this country, we work with the NMCP and their partners to define the research question, to define their need, their gap, to identify a research question for optimizing SMC effectiveness, and to conduct implementation operational research project for improving, to better interpret the data they have for their surveillance, because it's also another issue, to target effectively the best period of the year, the groups that are those who really need the intervention, and the high-risk population, how to monitor the delivery, how to assess its impact, and we promote also inter-collaboration, because all countries are not at the same level, so we are really sharing expertise and promoting the collaboration. So it's a 4 years, it was a 4 years project, but we have now 1 year extension, and the idea is really defining with them a kind of baseline need assessment, organize several workshops with the NMCPs and their staff, the SMC focal point, the MNE focal point, all their staff. We are working with them. We develop how to write a protocol, how to really better develop the data collection tool, and how to analyze their different results, and also help them to disseminate. It's over the 4 or 5 years. And since last year also, we are really working with them on how we can better facilitate the introduction of the malaria vaccine, so RTSS or R21, seeing that these vaccines are mainly very, very effective. They are implemented in that highly seasonal areas. So these are some projects we've developed with the country, with the National Malaria Control Program. They really choose these projects. So that are their question, the research question we develop into project, or how to better monitor and evaluate, how to they identify the barrier of SMT uptake, how they can develop new strategy to all those, how to reach population, and how to adapt the target group. So as you can see, with the Ghana was trying to look their SMC coverage, because they had some factor associated with low adherence. So the Benin wanted to look at the effectiveness of SMC, so we developed with them a case control study. With Senegal, Senegal is the only country that are delivering SMC up to 10 years, but also 3 days dot. So they wanted to look at the cost effectiveness of the strategy. The Gambia wanted also to look at the adherence. Guinea-Bissau also, they want to look their data, look the DHI's data, how they better interpret, how they can assess the SMC impact with this data. So for the barriers, I'm not going to go into, because we have here the National Control Program of Mali, Guinea, and Nigeria. They will present just after me, and Burkina as well. Mali also wanted to develop a new strategy called Community SMC, and we'll see what it's about. Cameroon will look at the effectiveness. Senegal also using modeling to better identify cost effectiveness intervention for SMC, and we'll see also the other country how they better can adapt the targeting group. Niger, Togo, and Chad is still at the development stage, because they want also to investigate SMC in the nomadic population, which is something we can see in many countries. Nomadic population could be an issue with all health intervention. So as an update, within that 13 countries, 3 has already completed the study, even at the stage of publication. Nigeria even published already the facilitators and barrier to SMC in Nigeria using a qualitative approach. 5 countries are on the analysis stages, 2 are ongoing data collection, and 3 remaining 3, the Gambia and the Guinea-Bissau, we are just waiting their ethical approval to start this year. And Chad, as said, we will still discussing with them about the nomadic population. We present those results in many conferences, the ASTMH, but also the EDC forum here, and these are the abstracts submitted to those conferences. Within this project, also we get the opportunity to have some co-funding with WHO, with the Wellcome Trust, with the use of video ads. We developed some cartoons really to improve the quality of seasonal malaria chemoprevention. The cartoon has been shared via WhatsApp or via social media with the NMCP, with the community health workers, and it showed a great adherence, and also people really like this cartoon to improve the SMC. And we, with WHO also, we developed some standard protocol of implemented research. We are also working with GMP about adding a module on SMC module on the DHIS2, and also we contributed to the revision of the field implementation guide. We, at the beginning, also, during the COVID, there was some delay, but we developed a study looking for the impact of COVID in the SMC campaign in that certain countries. And as I said, we had a meeting with all the API program, but also the National Malaria Control Program to see how we can really facilitate the integration of this new vaccine coming in that SMC areas. As a communication and visibility, we had a newsletter. We also used the collaboration with the SMC Alliance in their website. Some updates have been also shared during that SMC Alliance annual meeting. We developed some social media activities and during the World Malaria Day, also during this 10 years anniversary of SMC in Guinea, we developed some many tools, communication and media tools, but also webinars, meeting with the NMCPs, and also some publication, as I said previously. So this is a very short summary of this 4 years program of optimizing seasonal malaria chemoprevention. And I would like really, at the end, to thank very deeply and thoroughly the National Malaria Control Program. Some of them are here, Dr. Kone, Dr. Professor Alun Kamara, and the SMC Focal Point, to really thank them for this very great collaboration we had since 3 years now, and we hope we're going to continue with them in the next coming year. And thank you for your listening.
Thank you very much, Professor Ndiaye. So that's it, coming. So there will be no question immediately. You park your question, and then there will be all the questions at the end of the session. So now we're going to move to the first research project. Dr. Nena Ogbulafor, difficult name. She is the NMP Malaja Director in Nigeria. The floor is yours. Thank you.
Thank you. And good afternoon, everybody. Thank you, Prof, for setting the pace. So I'm going to be presenting on one of the studies that was done, like Prof has said, and that will be community perception and public engagement, a qualitative study in 5 states. So as a way of introduction, SMC was adopted in Nigeria in 2014 after the WHO recommendation in 2012, and in-country pilot that was done in 2013. And since then, SMC has been scaled up. But in 2022, we have SMC scaled up in the country, in 21 eligible states in the country, and that represents 2/3 of the states in Nigeria. As at 2022, we had over 27 million children reached with this very impactful intervention. And so this is like a map that guides through how we've done the scaling up since the 2013. And you can see 2022, the map for 2022, which shows more than 2/3 of the country being covered by this intervention. And so, of course, the aim of the study was to determine facilitators and barriers to uptake of SMC in the country. Having increased to that large extent in the country, we felt we should be able to, talk to everybody to get perceptives of all the both implementers, both the caregivers, to how we can do it better in Nigeria, implement it better in Nigeria. And so specifically, we looked at knowledge of malaria, whether it affects uptake of SMC, and to examine perceived effect of SMC on their children's health. So all through to health workers' attitudes and experiences regarding delivery of SMC in Nigeria. And so methodology, like was said, we purposefully selected 5 states. The 5 states in some of the states in the country that is also implementing, and they include Kano, Kebbi State, Kwara State, Nasarawa, and Yobe. And so out of those states, we chose 2 LGAs in each of the states to implement the study, and 2 wards out of that. And these were all based on both geopolitical zones, partner mapping, number of years that SMC have been implemented in the various states, and so on. And so the study population were caregivers, mothers and fathers, which was split into those who could read and those who couldn't read, community drug distributors. These are the health workers that implement at the community level. And then, of course, community leaders, LGA, malaria focal points, and directors of public health in these 5 states. We also involved the national program at the national level, also our partners, our key partners in the country on SMC, which include Malaria Consortium, WHO, PMI, Global Fund. And so we did collate data through key informant interviews, in-depth interviews, focal group discussions, and we had huge quantity, large number of data, which came to over 190 information that was gathered. And data analysis was done through content analysis and thematic analysis. It was narrated, the results were narrated and produced into 10 thematic areas. Those thematic areas were major health problems in the communities, and then knowledge of malaria among caregivers, barriers to SMC uptake, and so on. And of course, recommendation on how to also upskill SMC uptake was also part of it. And so some of the facilitators and barriers are as shown. So we have like friendly CDDs as a facilitator, even if that could come to 2 sides of the coin, you know, both on the negative side and on the positive side when we looked at those interviews. And then unfriendly attitudes of the CDDs in terms of barrier. Mistrust was also mistrust / induced rejection, you know, few isolated cases of that. And then also on facilitators, we had support and empowered lead mothers who were also part of the team that was implementing this very insightful intervention. And so some of the quotes from the research we have were very interesting, like taking one of the facilitators, which was model of delivery via door to door. We had, like, for example, a female caregiver from Yobe State who was saying, if the drug is to be distributed at a fixed point, there will be overcrowding and stampede during collection, and this would deter some mothers from going to the facilities for collection of drug for their children. Also, on attitudes and behaviors of CDDs, which were all part of the thematic areas that were picked. Also taking maybe one of the negative and one of the positive. A female caregiver from KB said, some mothers who do not take the drug for their children feel that the community drug distributors were hostile to today. So that's part of the negative effects that we picked up, but on the positive, based on that too. Some of them, one of them from Yobe said, offers greater opportunity for engagement between caregivers and CDDs. The CDDs come to enlighten us on the drugs, how best to use it, the time to administer it, and how to notice any development that may arise. So on the barriers to uptake, which we think is also very important because some of these barriers have hampered some very useful intervention in the past in Nigeria, like the polio. So we have like a caregiver in rural Kano who said some people have a belief that their children will be harmed when they take the drugs. That is why they do not accept it. For instance, some people believe that the drugs can cause infertility in future. So those were the kind of barriers to uptake that we were seeing from the study. And then on incomplete coverage stroke, local shortage of drugs / hard to reach areas, we had taken a male caregiver from Nasarawa State who said the drugs are inadequate in this community because it does not go round to all, especially here in the Dadiri Kokona LGA in Nasarawa State. And so some of the quotes from stakeholders and funders were very important to us also. And so just looking at the U.S. President Malaria Initiative stakeholder from Abuja who said to ease financial burden, government should make deliberate effort to harnessing domestic fund for SMC. Furthermore, since the driving cost for SMC is on payment personnel, volunteerism at the community level should be promoted to reduce costs. And so key findings and recommendations from the study included in all study areas, malaria was seen as a major health concern, which is synonymous with a lot of other studies that have been done. And then, of course, we have general community drug distributors were trusted. Generally, community drug distributors were trusted. And then some isolated concerns on perceived side effects and safety of medicines, shortage of medicines during drug distribution. And then, so the recommendation was focused on addressing the concerns of the caregivers and program managers with respect to the identified facilitators and barriers. And so at country level, what have we done? So far, we have, the study has been disseminated widely in country to all stakeholders, including at international fora. And so we also had key findings and study results shared with delivering teams, the SMC delivery teams, during the 2022 national and state level trainings, and cascaded down this training even to the community drug distributors at their level during the LGA and community level trainings. And so based on that study, we were able to discuss with funders like Global Fund in country, and so we were able to secure funds from partners for the revision of training modules to strengthen communication about SMC safety and effectiveness, and also increase involvement of state-level pharmacovigilance coordinators through a workshop on pharmacovigilance that produced documents like risk mitigation documents, among others. So we also scaled up the use of digital technology for implementation to improve efficiency and accountability of SMC. So some of the findings from the routine SMC programmatic assessment that happens, the LQAS, in 2022 and 2023 has showed very marked increase in acceptance of SMC among other findings, which is very, 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 very reassuring. And also we have measures to avoid local shortage of SMC drugs through maintaining micro-planning allocations, as they were in that current year for implementation. And also emphasis on recruiting distributors from local community for the implementation. Also, we did have intensified advocacy for SMC funding across all levels of government, just to also reiterate that for the state government now, even at the national too, we have a lot of the governors, putting money for the implementation of SMC in their various states. And just like Prof had said, the study has been published in Malaria Journal, and then we're looking forward to a second manuscript in preparation for another publication because we actually had a huge data collected from this study. Thank you.
Thank you very much, Dr. Nena. Very nice presentation. I would invite now Dr. Aissatou Bari from the National Malaria Program of Burkina Faso. She's the head of the Monitoring Evaluation Department. The floor is yours.
Good morning, everyone. I am Aissatou Bari from Burkina Faso National Malaria Program, and thank you for giving me the opportunity to share our data on evaluating the determinant of variation in SMC coverage in urban area in Burkina Faso. The principal investigator of this study is Dr. Tougri Gauthier, the head of National Malaria Program from 2019 to 2022, and the general coordinator of this study is Dr. Sie Ali, the head of Centre de Recherche en Santé de Nouna. As you may know, SMC is one of the most cost-effective interventions in the era of malaria eradication. SMC was adopted in 2014 in Burkina Faso and expanded to all districts in 2016. SMC in Burkina Faso is given over 4 to 5 rounds from July to November to all children between 3 to 59 months. SMC coverage across region in Burkina Faso is high, around 8%. However, there are disparities between urban and rural health districts with lower coverage in urban area compared to rural areas. Our primary objective was to determine the reason for the disparity in coverage of SMC campaign between urban and rural areas. The secondary objective were to compare barriers and facilitators in the adoption of SMC in urban versus rural areas, to identify best practice for improving the coverage and quality of SMC, and finally, to propose realistic and relevant action to improve SMC coverage in Burkina Faso. In Burkina Faso, we have in total 70 health districts, and this study was conducted in 9 districts. 4 urban districts with low SMC performance, Basqui, Nongre-Masson, Dafra, and Do, and 5 rural districts with better SMC performance, Waiguia, Dédougou, Karangasso, Vigue, Zorgo, and Puitenga. From each health district, 2 local health facilities were selected, giving a total of 18 urban and rural local health facilities. The study population was mother or legal guardian, father, community distributors, health facility, and AP manager at local health facility level, head and AP manager at district level, regional health director and input manager at regional level, decision makers at central level such as SP PALU, and other stakeholders such as PMI and Malaria Consortium. It was a qualitative study that combined both focus group discussion and in-depth interview. In total, between October 10 and November 10, 2022, we did 86 IDI and 44 FGD. Here you can see the framework that was used to guide the team during the qualitative studies. Programmatic factors such as planning, procurement, training, supervision, communication, community factors such as geographical coverage, social mobilization, acceptability, and medication factors such as safety, resistance, and side effects are potential factors that can influence SMC coverage and therefore the impact of SMC in terms of reduction of malaria incidence. In this slide, you can see the detail or number of interviews per technique and per target. So we did in total 3 IDI with stakeholder, also 3 IDIs with central level decision makers such as SP PALU, and 8 IDIs with mother and 6 with father. Regarding the focus group discussion, we did 15 with mother and 16 with community distributors. Interviews were recorded, transcribed, and coded using NVivo 12 qualitative analysis software, and thematic analysis were used for data exploration. And as you may know, before the start of the study, ethical approval was obtained from the National Ethics Community, and informed and free consent obtained from all study participants. What we found as the challenges of SMC delivery in urban area, the high population mobility, and also the problem in estimating the target population that is shown in the code below, that we got from health worker at district level. We often find percentage higher than 100, and we have even seen places where we have reached 150%, 160%, or 170%. So on the one end, because the population were underestimated at the start, and the other because the displaced population. And here you can see a quote regarding the population density and the expansion of major cities like Ouagadougou. Ouagadougou is too vast, and even if you get up one day and want to supervise, you can't go from door to door, checking all the doors in an area to see if they all receive the drug. Here you can see a quote regarding the lack of training of CDs. I'm not gonna read all of the quotes. We also found challenges that are not specific to urban districts, such as insecurity. Currently in Burkina Faso, we face a security problem, and this is a challenge in terms of SMC delivery. The campaign period, when people in rural area are more preoccupied with field work, and also the overlapping of SMC round with over malaria control intervention. There is also community perception that make difficult the delivery of SMC, such as the negative perception by the community of free FK intervention, the population hesitancy in the context of COVID-19, and the doubt and mistrust in urban intellectual circle. And this is clearly explained in the quote below that we got from health worker at local health facility level. In Ouagadougou, we are in intellectual era, so when you go out, you have to be prepared for everything, because there are over who want to see if you have a mission order, who send you, and they will even check the notice first. Because you know that there are fake. Well, we are not going to say fake, but strict door. So people have that. The era is full of old people, because the old people are retired teacher, retired gendarme, retired lawyer. So we are a bit suspicious of everything that goes on here. We also found facilitating factor in rural areas, such as support and guidance from community leader, the use of community health worker, community relay in rural area, and their proximity to the population that improve the acceptability of the campaign. As a facilitating factor in rural area, we also have the fact that the children are less socially isolated, so it is easy to group them together and administer the product at home or at market. And also the use of public crier in a rural area that is a much more appropriate channel for circulating information in rural area. Here you can see some best practices that can be used to improve the coverage and quality of SMC in Burkina Faso. The involvement of extra persons specifically for communication during administration in the household. The organization of performance feedback meeting to enable stakeholders to share their experience, the production of T-shirts for CD and supervisor to raise the profile of the campaign, and the administration of drug by the child mother under observation on day one. The diversification of communications channel and culturally adapted message, the introduction of recreational activity to reward a group of children who have not contacted malaria thanks to good administration by the mother. The availability of input before the start of the campaign, the use of toy or sweet to encourage children during treatment. And as a recommendation, to digitize the campaign to improve data quality for better decision making, to recruit a sufficient number of CD who know and control their coverage era, involve community leaders in distribution, give priority to student trained in health school when recruiting CD in large town. As a recommendation, we can also improve support for supervisor and CD and make resources available to maximize on the dynamics of CD and the level of education in order to face the question of intellectual population. Involve private healthcare structure in order to reach children from privileged background, and use social media network such as WhatsApp for communication in urban center, and start raising awareness a month before the campaign begins. And in conclusion, the study identified the challenge to SMC delivery in urban area and the factors that are facilitated its adoption in rural Burkina Faso. Good practice adopted by some rural health facilities have enabled them to achieve high coverage performance. These strategies will be applied in urban area in order to improve coverage and the quality of SMC in Burkina Faso. Thank you.
Merci, Dr. Aissata. Oh, sorry, I was in French. Thank you, Dr. Aissata. I mean, really, the urban area is really an issue of many intervention in health. So now we're gonna hear about Guinea, which are also targeting the mining area, how they can improve SMC. So with Bienvenue, he's a social research scientist from Guinea who is really supporting the National Malaria Control Program.
Thank you so much, Professor. So I'm going to present the finding of a study about optimizing SMC delivery in the Sigiri mining zone in Guinea. And as background, Guinea started SMC in 2015 and scaled it up from 2015 to 17 districts. And SMC consists of 4 cycles. One district runs or has been running 5 cycles since 2021. SMC is also mutualized with household-based health services such as referring children to catch up with immunization. And the graph you've seen show the coverage of the service for each cycle and in each district. And you can see the one cycle in red, which is the district of Sigiri, present a consistent low coverage as compared to the other district. And curiously, it's the district that has the largest target population. And the graph below is from surveys, previous surveys, which are showing also the same coverage pattern. So this made us tackle these objectives. The first one is to understand facilitating factors and barriers to SMC uptake in this mining zone of Sigiri, to adapt the SMC delivery strategy to optimize uptake, but also to assess effectiveness of the adapted strategy on SMC uptake. You can see the mining district of Sigiri in the northern part of the country, and the study was conducted in the Doko subprefecture, where mining is one of the main activities. As method, we first conducted a baseline qualitative study that was in October 2020 with community members and SMC providers to understand reasons for this low coverage. Then in September 2021, we designed, then piloted an adapted strategy based on this reason for low coverage and through a participatory approach. And then from July to October 2021, we then evaluated the effect of this pilot strategy by doing 2 surveys. One was conducted before the 4th cycle to which we applied the pilot strategy, and then after the 4th cycle. So for finding, we identified 4 main facilitating factors, 2 from communities' perspectives, of which you have the perceived effectiveness of SMC, but also the perceived economic benefits of SMC. From providers' side, there was cooperation between local authorities, partners, and communities, but also the on-the-job supervision. As barriers, we identified various ones. From community perspective, one is the perception that what is free is a poisoned gift. And a father of a child illustrates, here, when they say it's for free, Some people think it's a poisoned gift. They think it's to make their children sick. Another barrier was doubts about treatments to healthy children. A distributor illustrates. You know, it's usually when someone is ill that he is given medicine. So people have doubts when we ask their children to swallow medicine when they are not ill. Another barrier was the perception that distributors who are not native from the neighborhood or the local community are seen as outsiders. A distributor also reported, SMC is not easy here. There are many in the community here. As soon as they see you are a foreign body, they refuse everything you ask for. There were other barriers from the community sides, including influence of COVID-19 on their trust toward SMC, perceived risk of adverse reaction to SMC, perceived excessive number of preventive medications, and non-retention of SMC records cards by some caregivers. From the provider side, we also identified number of barriers. One is that distributors, some are living far from their distribution areas. And one said, some are sent to villages more than 20 or 30 kilometers away for SMC. By the time they get there, many of the children's parents are already in the farm. Another barrier was the high assigned workload related to the working hours. Another supervisor said, it is difficult to have 80 children a day, which is the target number to treat per pair of distributors per day. We struggle, but we can have 30, 35, sometimes 50 children. There are many parents who refuse. Another barrier is that some distributors leave work for some of the monthly cycles. In the field, I had informal conversation with one who said, no, last month I was in Cancan, which is another district. I had gone to the school for exams. So the head of the health center replaced me with someone else. When I came back, I took over again. But the problem behind this is that the one replacing the distributors are not trained. So they consume more time in households trying to distribute SMC. The other factor or barrier is the insufficient number of local advocates, community mobilizers. The head of the health center said, for the health center, you have 2, sometimes 3 social mobilizers who have to go around many villages to raise awareness in the household, which is not feasible in reality. One of the problems behind this is that also these mobilizers going to other communities or neighborhoods to sensitize or raise awareness are considered there as outsiders. There were other barriers, including the fact that some distributors were unfamiliar with their distribution areas, some lacked technical knowledge about SMC, remuneration was told to be too low, lack of field visit by some local supervisors, but also it was reported mobility of households which move often from village to another in search for gold mining. So based on all these barriers and suggestions from the local stakeholders, we adapted the routine SMC strategy at 3 levels. The first level was about the selection of distributors. For each pair of distributors, one had to be from the neighborhood where they distribute the SMC, and one had to be literate, and both had to be available for all the 4 cycles. The second point was about distributors' workload. So the number of distributors were increased to allow more time in households. As such, workload was reduced from 80 children to 40 to treat per day. And the third point of adaptation was about community mobilization. In each neighborhood, one local person was recruited for community mobilization. There were also awareness-raising messages that were broadcasted on local radio. So this pilot strategy resulted in a significant increase in the coverage of SMC, as you can see in cycle 4 in the intervention area as compared to previous cycles. But also when you look at in the control area, and this is a tradition that SMC coverage increases from one cycle to the next one. This means that thanks to this pilot strategy, the coverage was highest for the fourth cycle. The pilot strategy also increased caregiver trust in the SMC program. The blue bars, which means after the pilot strategy, shows increase in the proportion of caregivers who believe that SMC will not harm their children, that SMC is effective in preventing malaria, that the local distributors, they prefer the local distributors who came compared to the previous one, and that they had confidence in the information given by distributors, but also that distributors visiting the household were known to them. One positive effect of this pilot strategy is that it increased also the strength in community mobilization thanks to the neighborhood advocates. And they represented 71% of caregivers' information sources about SMC as compared to 21% before the pilot strategy. So as conclusion, we can say that to optimize uptake of SMC, there is need to adapt the delivery approach to the local context, but also using neighborhood distributors increased trust of caregivers in the SMC program, and that increasing the number of distributors increased costs but made it possible to reach the target number of children with SMC. And also local advocates were effective in strengthening community mobilization. One point of attention is that this study was completed in 2021. So we think that there is need to understand, maybe through a qualitative research, how these findings could be put into practice for scale-up. Thank you so much.
Thank you, Dr. Bienvenu. The last country presenting is Mali with Dr. Madi Sissoko. Madi Sissoko is a SMC focal point working at the National Malaria Control Program in Bamako in Mali. Madi, the floor is yours.
Thank you. Ah, ok. Ah, ok. Ok, j'enchaîne juste.
Voilà, il faut juste enchaîner. Là, on va devoir...
Ok.
Donc, tu vas aller jusqu'à ta présentation.
Okay, thank you for the floor. My name is Madi Sissoko from National Malaria Control Program in Mali. The study I want to present for you is evaluating 4 approaches to improve coverage and adherence of SMC in one district in Mali. SMC was adopted in Mali in 2012, and gradually is extended for all districts in Mali. The stratification with 2020 in 2020 we adopt some stratification of malaria risk. We decide to select for 43 districts to implement SMC for 3 to 5 cycle. And the SMC for the SMC delivery, you have 3 model: door to door, the fixed center, and the mobile center. To the administration in Mali, the teams give the first dose, and the remaining dose is left with the parent to give to the children for day 2 and 3. The SMC in Mali include the training of malnutrition, the testing of suspect malaria cases, and the administration of SMC drug according the different pictures and down. You decide the study because of you have some shortcoming in the SMC in Mali. The first is the low adherence of SMC, the adherence of second and 2 dose, the low of the coverage, the absence of a parent at the time with administrator visit, the importance of effective community about SMC, and the increasing of malaria incidence for children. I need to go back. Yes. Non, ça marche pas. Non.
Je pense qu'il va falloir ressortir du coup. On est obligé de ressortir et de revenir sur notre... Il n'y a plus rien qui marche. Ok, je vais appeler. Ok, je dois appeler.
Oui, c'était les objectifs.
342, ouais, s'il te plaît.
OK.
Attendez, vous touchez à rien, il va faire à distance. D'accord.
OK.
Sorry, just a technical issue. 1 minute, please.
On était en avance. Le technicien gère à distance. D'accord. Non, ça passe plus. Non, tu vois, ce que tu fais, c'est... Ouais. Ok. Parce que tu sais, c'est la présentation qui est globale. Ok. Ben non, ça marche pas. Continuer un petit peu à l'oral ou pas?
Oui, c'est...
Okay. Touchez à rien.
Okay.
Touchez à rien parce qu'il est en train de essayer de le faire.
Okay, thank you. For the study, you decide to formalize 2 research questions. The first research question was, what can I do to improve the what can I do to improve the adherence and the coverage of SMC using the community volunteers. And the last one was to do something who is low costly for the SMC. The different specific objective of the study was to evaluate the coverage of during the study and the C'est bon, c'est bon. It's okay. Yes.
Tu peux nous remettre au début?
Yes. Non, non, non. Continue. Yes. Continue.
Oui, oui, je suis en train de le faire.
Non, non.
Okay, vas-y. Après?
Yes. Go.
C'est après
présentation. Ouais.
Ok.
On finit cette présentation, ouais. C'est la présentation suivante. Voilà. Ok, c'est la suivante. Voilà.
Vous me dites tout.
Ok, c'est bon.
C'est bon?
Yeah.
Okay.
Okay, thank you. The specific objective for the study is to access the feasibility of the two approaches and the impact of SMC coverage and adherence, to understand the community perspective about adherence and attitude to the intervention. We estimate the cost of the new approach and monitoring the incidence of the malaria for children. For the method, we choose one district which is located in the high transmission area of malaria in Mali. 6 health area was chosen, 2 health area per approach. To the description of a different approach, the current approach name is the standard SMC, with a distributor in teams of work for 5 days each month, visit each health household once to administrate the first doses and left the blister with the family to give a dose of on day 2 and day 3. The community SMC is the same as a standard SMC, but you added the community volunteers we visit for the dose 2 and 3 to explain SMC and when to explain about SMC, explain why to write on the SMC card the daily doses, check the blister packed. If the AQ dose has not been used, then assist the family to administrate and to complete the SMC card. The last one is the strategy approach of DOT, which involve over three days per month. The distributor come all day to give the SMC drug for the children. And this slide, the SMC, the community SMC volunteers are chosen with the community association, the health association, with the head of health center, and you receive some per diem every month for 6,000 per month. We can help the association, and we benefit some training before the first cycle of SMC. For the distributor, for the standard SMC area, we use 48 distributor, and for the DOTS approach, we use 2,000 distributor for over 3 days. And the last one, you use 12 distributors who work 5 days and 43 volunteers who work 6 days to follow up for giving second and 3 doses. For the collection data, the SMC was planned for July to October, and you make the survey after the last one to collect the information of the administration of SMC. We choose 24 households per approach, and we survey, collect the information basis the SMC card, and the parents were asked about the treatment adherence and the blister packet, inspect for leftover medication. For the incidence information, we collect some individual patient recording for clinical register during 2020 and 2022. For the cost information, we collect all additional cost information. Maybe the cost, the training of volunteers, the supervision, and the supervision and the additional volunteer distributor. For the data collection of the qualitative part, we make 70 interview and 3 focus group for health provider, distributor agents, the community leader, and the key informant. For the result, we have for all approach very high adherence and very high coverage, which was the surprise for this study. For the cost of a different approach, community SMC was less cost than DOT, but it's very higher than standard SMC in our study. For the qualitative, you summarize this part with the prompt of 3 participants in the study. One of standard SMC who asked where is too much passage in the standard SMC strategy because the drugs are given to over people. They don't give them to their children. Then their children will not be protected against malaria. If you try to see where you are a lot of parents of children who don't give this over 2 doses what have been given to him. After the campaign, packets of SMC pills were shown in the garbage ban, and some family indicate that these doses are not administered to the children. For the some participants of the DOT approach, we think that it's a good strategy. We say that wherever women who free away the rest of the drug, instead of giving those over 2 doses for children. For the participants for community SMC, for me, they have to continue with the strategy with community monitoring because mothers of children are not the same. There are some who give the drug correctly to the children. There are some women who don't give correctly the drug. If you say that the volunteer have been asked to visit the family to see if the doses have been administered, all is for to successful of the SMC. When you spend money on the job, you will have to follow up if it's correct or no. Following is very important in SMC. For the incidence rate of clinical malaria for 20 to 2022 in children under 5 and older age group in blue. In the true zone, you can show in the curve the period of intervention, which is 20 and 22. The trend over time differ between the different the intervention and the control area, using the data for all age group to control for this. The estimate of the intervention effect from patient aggression is 22%. Il trouve there is no clear evidence on the intervention effect. The data do not exclude the benefit of the both intervention. To conclude with the study, who is a plan to evaluate two alternative approach delivery of SMC in Mali. 3-dose dot is become more widely used to concern about adherence, but dot is costly and there is limited evidence about power, adherence, and benefit of dots. We evaluate the community strategy to promote the adherence using local volunteers, qualitatively caregiver and distributor highest power adherence, and we need for the strategy. There were positive attitude to the strategy and it's less costly than DOT. Report adherence and survey was high with all strategy, but maybe affect the reporting via objective method by need. Adherence is a potential concern, but simpler strategy than 3-day dots by SMC teams may be more effective. And after we study, NMCP Mali plan to make the community SMC for all one district in Mali, whose name is Jene, and you can show the malnutrition group of support of a group we participate for SMCP campaign in Mali. Thank you for your attention.
Thank you, Dr. Madi. I mean, you can see how this control program has generating evidence-based information and how they can adapt and decide of what they are going forward. So we are now listening Fatimata Bintousal, the research assistant from University of Thiès, for the last presentation before we start the discussion. Fabi, please.
Thank you for the floor. Good afternoon, everybody. I'm Fatimata Sal from the University of Thiès, and I'm very pleased to close the presentation for this session to make a brief summary and to open up discussions towards the perspective for the control of seasonal malaria. So here is just to summarize the main strength of the OPT-SMC project, who managed to connect 13 countries, sharing progress and lessons learned. And during this project, the National Malaria Program took the lead of the research. They identified themselves their priority question, conducted research, and put findings into practice. And this has been made easy by the valuable technical support provided by the OPT-SMC team, as well as capacity building in implementation research methods. And given the several activities covered by the National Malaria Program, we know that it's not always easy for them to conduct themselves research. And during this project, OPT-SMC was able to facilitate meaningful collaboration between the National Malaria Programs and local research institutions. We were able to maintain frequent communication with each NMC through virtual meetings as well as in-person meetings, creating opportunities to exchange with all partners. And it is also important to highlight the inclusive approach of this project with French, English, and Portuguese-speaking countries. Some common themes came out during this project implementation. First, we have mistrust, as we have seen from the previous presentation. Mistrust concerning safety, suspicion about drugs provided for free, communication issues, and hiring distributors not from the local community were common barriers to SMC uptake. It is clear that the SMC delivery strategy needs to be adapted to the local realities, and this highlights the importance of qualitative research to understand community perspectives and to be able to take them into account when planning SMC delivery. In some area, we have seen that the main challenges for SMC delivery was security problem. And another issue that came out is the additional cost needed to implement the recommendation from conclusive results from research. The question now is, what are the perspectives for the control of seasonal malaria? Countries should keep optimizing their SMC delivery as long as SMC is still a proven success. And the new SMC implementation guide from WHO raises practical questions about SMC optimization. In its latest guidelines on malaria, WHO recognizes the need to adapt strategies to local epidemiology. In particular, countries should be able to address the questions: where should SMC be done, when to start, for how many cycles, when to stop, and also which age range should be targeted. It is also important for countries to improve their surveillance data collection, making data more detailed in order to better characterize the local malaria patterns. Always in the context of control of seasonal malaria, we have upcoming interventions, including the malaria vaccine, which countries should start to implement from 2024 for additional protection. We also have potential future interventions, including the antimalarial monoclonal antibodies or the long-acting injectable antimalarials, and developers should start now to think about the delivery strategy. And we think that similar implementation challenges to ensure that all the target population will be reached can be encountered, and an approach similar to that of the OPT-SMC one may be helpful in supporting countries to identify and overcome the barriers of delivery. Thank you for your attention, and all the team will be happy to answer to any question.
Thank you, Fabi. Now we are at the end of the presentation, and the floor is open for questions and comments. I think there's a microphone available. Please present yourself and quickly. Thank you very much. Yes, Mohammed.
Excellent presentation from across the countries. My question goes to Dr. Bienvenue Kamara from Guinea. You had some very insightful feedback from parents in the community in respect of the perception that when the drug is free, then it is considered a poison gift. So I don't know whether you probe further or you assess their willingness to pay in case this drug is not available free of charge. Are they willing to pay for the drug? That's number one. Then secondly, I find out, or I observe that after you, I don't know which intervention you did, and post-intervention assessment show that they develop more interest and more trust in the system. So whereas during or before the intervention, they had some level of mistrust. So what actually happened? What did you do that sort of address the mistrust that they had and improve the high level of interest that you reported post-intervention? Thank you again.
Thank you. We're going to take a series of 4 or 5 questions before getting the response. Umberto? Or?
Okay, thank you very much, Umberto D'Alessandro, MRC Unit de Gambia at the London School of Gene Tropical Medicine. First of all, I would like to thank all the speakers. I have a few comments. One is also, I would like to underline the partnership between implementers and academic institutions. I think it is very important, and it's important that this is promoted more. I have a comment about the SMC in urban area, because clearly that intervention in urban area is usually, not always, but usually urban area transmission is much lower. But also the context is very... So I think there is a need for thinking what is a different strategy for urban areas. I don't know what, how, but it needs to be different from rural. And then the last one is about surveillance. everybody, and even the last speaker said the importance of surveillance and of collecting data, and Ministry of Health should be able to use the data collected to refine and target their intervention. But this is always said, but it's hardly done. It's hardly done. So, and this is not only for SMC, but also for all other control interventions. So it's really important to stress, to put resources into this. Thank you.
Thanks, Umberto. Here,
Good afternoon, everyone. My name is Nobu Fada from Babcock University, Nigeria. First, I want to thank Professor Ndaya and his team for the wonderful presentation. I have a series of questions. First to you, Professor. Well, I want to appreciate you bringing in the malaria control programs from the Health Institution of Health from all the countries, which was very commendable. My first question is that in bringing this consortium together, was there thought given to the transmission intensity? Because from these different countries, they have different transmission intensity for malaria. Was that factored in when the study was being done? And then were there consideration of, for instance, the SMC has to be done over 3 days, that adherence, where there is no adherence, could it lead to malaria resistance? Because that's a major issue that has been on the floor. And then the last question, I also talked about the issue of surveillance of the efficacy. Then the other thing is the local production of the drugs, because in some of the presentation, sometimes the drugs are not available, and then that can lead to mistrust in the community. Then for Dr. Nina, my question is, thank you. I'm very happy that I got to meet you here. There is a great discrepancy between coverage of the North and the South in Nigeria. I have been wondering why that has been. And then I also wanted to throw light on Nigerian government support for this program, because funding this thing had been very, very challenging because of the number of children that are supposed to be covered over the period of time. And then finally, this is also a major question, that when this program ends, what plans are there for sustainability? Because usually in programs like this in Africa, once the funder and the partnership ends, the programs end there. So is there any plan to have a sustainability for this? Thank you very much.
Yes, Tinto.
Mine will be very short.
Sorry, we'll get back to you then. Yes.
Okay, so I'm Halidou Tinto. I'm coming from Burkina Faso, the Clinical Research Unit of Nanoro. At the end of the presentation given by Fatimata, she mentioned new tools, including malaria vaccine rollout next year. I would like to hear the control managers, their opinion about the combination of SMC and the vaccine. Thanks.
Thanks. Just behind, there's 2 hands there.
Thank you. My name is Thomas Jan from Kintampo Health Research Center, Ghana. Mine goes to Prof. Ndai. Prof, with the priority research companies, I would like to know how they were evaluated that informed the projects by the countries. Thank you.
Thank you. My name is Vera from Ghana. And my question goes to, or it's more or less a comment to the rep from Burkina Faso. She mentioned that in the rural areas, there are a lot of high mobility, so they are unable to get a lot of the persons. And I'm asking, where do they travel to? If they travel to other areas, maybe planning the SMC, that when they move from one place to the other, if they miss it in their community and they get to the next village or the next region, they will take it over there. And if they are migrating to Ghana, since we are neighbors, Ghana also does SMC. What about maybe collaborating or having a discussion with the Ghana NMC And then if they miss it in Burkina, they can take it in Ghana. So we know that there's a coverage exhaustion everywhere. Thank you.
Okay, so we're gonna just go to the answer before, if we have time, we're gonna take other questions. I see the first question for Bienvenue, yeah?
Yes. Okay, thank you so much. So the first question that was addressed to me was why like caregivers are still saying what is free is, sorry. Thank you.
Yeah, I just stay here. Okay. So the question was whether these caregivers are able to pay for medicines if it was not for free, because they are saying what is free is a poison's gift. Yes. So I could say give 2 points as answer. The first is that in the mining zone, as compared to other zones, they have more capacity than other areas. So though still paying money for malaria can be, they can feel it as expenses, but not that as compared to those who are not in mining areas. The second point is that it's like traditionally they still pay, even if it is in the context of free care policy, because serious malaria is not for free. And it might be also simple malaria, but they can also buy like paracetamol or other comorbidities can lead them to pay. But being illiterate, they don't know whether really malaria is for free. I mean, treatment is for free. So they just consider the pay. So why now, while their children are not sick, they are telling them, take this medicine for free? And the other question is, what did we specifically do to increase trust? So there were like 3 main points. We increased, like we selected neighborhood advocates. Like in each neighborhood, we recruited a local person to mobilize, to increase awareness. As compared to before, there were just 2 or 3 who should move to neighborhood where they are well known. The second point was also for distributors, we also recruited one from the neighborhood where they should distribute. And we also increased the number of distributors, which gave them more time to spend in each household. Therein, they had more time for communication. Thank you.
Thanks. Dr. Nena, I mean, there's a question about the shortage of the drugs, but also your feeling about combination with SMC plus the vaccine.
Yes, thank you. Thank you for the questions. Yeah, Prof, I heard you, but I also know that he was talking about coverage in the north and south. Yes, so I would like to remind you of those maps that was shown. You know, so those 1/3 that didn't have SMC is actually the southern part. And you know that SMC is implemented with evidence-based because it's seasonal, and it has to do with the rainfall pattern. If you look at what is happening in Nigeria, in the southern part of the country, we have perennial rainfall almost all through the year, and you cannot implement SMC. I know that a lot of questions have been asked, concerns about that, but Nigerian government is still hands-on on coverage for under 5 children in the southern part of the country. Currently, we're doing pilots on PMC, you know, perennial malaria chemoprevention, and if we're done with that, hopefully, we should be able to be covering the southern part for under 5s in Nigeria. So that's one of it. And then what is Nigerian government doing to support? A whole lot, just like we said. Part of what also came out is from the study that we have done. So the state governors actually, or the state government actually, you know, carry out advocacies before this, the SMC intervention starts every year. So what they normally do, there's a big fanfare. most times the governor's wives, come out to flag off this intervention. They are shown giving these medications to children, and so that also increases, and monies are used from state government to plan all that and do all that. Also, the state government is also involved in the last mile distribution for commodities from the warehouses down to the health facilities where the drugs are used, for the implementation. Also, generally, we know that even me as an NMEP official, I'm being paid by government, and I also implement SMC. So the workforce, generally, even from the national, the state level, and other things that are involved in implementation is also being supported by government. So those are kind of the intervention or the help that and support that government of Nigeria is giving across board. A quick one, maybe on SMC and vaccine. We would like, yes, we would like a situation where we would want SMC, because SMC is huge, it's rollout huge in countries like Nigeria, and because we know that it is an accepted intervention, So we think that a new intervention that is coming, like the vaccine, should also ride alongside SMC. There's a huge opportunity for SMC to go along a lot of intervention, and even with WHO recommendation that is saying that interventions are better when they are combined and going together. So we really think that the malaria vaccine should run with SMC across board, both for those interventions that will be done in the southern part of Nigeria and in the north, like the SMC. Thank you.
Thank you, Dr. Nena. Maybe Dr. Aissata, there's a question about the trans-border collaboration. I know Umberto also asked a lot of things, comment about the urban areas and surveillance. But we can, everybody can respond to this one because.
Okay, thank you. Sorry. For your question regarding the mobility, I'm sorry for the confusion, but the mobility is in urban area, not in a rural area. And when the community distributors goes to the house, the parents were not at home. They are at market or at work. And when they are at market, sometimes it is with the children. So the high mobility is about urban area and not rural area. For the question of professor, I think I will leave the floor. Thank you.
Thanks, Aissata. Maybe mine have two questions about the criteria for his network. The entry point was the SMC implementing countries. And there was, at the beginning, there was mainly the Sahelian countries. So now we are trying to work also with Mauritania to see if they can also be part of that. And Côte d'Ivoire as well, in the northern part of Côte d'Ivoire. And you see there's other countries, South Sudan or Uganda, Tanzania. But mainly the thing is how to optimize the implementation. The other question was about, of course, the resistance. We've conducted in many other projects monitoring drug resistance. We are also aiming to do that. But of course, if the adherence is low, it should maybe, if the drug pressure is here, probably even if there's no deal actually for seeing emerging resistance, but we need to be monitored closely. And my last question about the priority. There was a challenge at the beginning because, the NMCPs, some of them are really trained as a research, but many of them not. So they are implementers. So working with them to set up kind of research question and now do an exercise of prioritization over the years since 2020, you see that it's like dynamics, very dynamic. So we are still working with them and helping them. That's really the objective of this program. Okay, if there's we have almost at the end. I leave my co-chair to do a kind of summary.
I will not do a summary. I would just thank you very much for being with us today. So then the idea was really to show some example of country-led research projects that help to optimize a fantastic public health intervention that is a huge platform for eventually nesting other intervention, like Tinto was saying, malaria vaccine might be a good one to integrate into this door-to-door intervention. But how to do that, it will be a need for new implementation research and new ways of discussion. And there was my nice experience where it was a participatory approach where with the community discussing the new strategy, implementing the new strategy, evaluating the new strategy. That's what is implementation research, and these are very interesting projects that have been conducted. In terms of sustainability, what have been built in terms of research capacity is built. But if we were moving to now also including the malaria vaccine, then we need to involve in this network other partners, probably the PEV, the AP department, and other colleagues. And just to finish on how to involve also the research institution. Of course, they are key in this story because the program are not professional researcher, but they should lead the research, and that's what we try to achieve here, for them to really understand their data, define their priority, and then lead the research that they can conduct themselves or in partnership with local research institutions. That was a successful story, and we hope there would be other stories like that in the future. Thank you very much. Have a nice stay in Paris.
Optimise.